We're going to talk about management of abdominal trauma in kids. But first, what I wanted to do is kind of just review some of the general principles of managing kids, because this is really relevant to abdominal pain. And unless you're kind of thinking about these things, it's, they're easily missed. And the first is that assessment and management of injured children are basically the same as an adult. So when you're taking care of a pediatric patient, you want to think basically the same thing, no matter how old the patient is. If they're a 3-month-old or a 6-month-old or a 10-year-old or a 15-year-old. And as we know, all those principles are airway, breathing, circulation, disability, and exposure. At the same time, even while those principles are the same, we all have to remember that children are not just small adults, and that children have unique anatomical and physiological characteristics that result in distinct patterns of injury. So what I wanted to do is just kind of review some of these, and this will kind of help with, as we discuss abdominal injuries, but these apply to taking care of injuries in general. So first, the smaller size of the patient results in a greater force applied per body unit. So if you can imagine a car going down the road and the bumper hitting an adult, that's very much different than if the car's going down the road and the bumper hits the child, because you have all this mass that's basically transferred to a smaller body area. As one of the consequences is that multi-organ injuries in kids are a lot more common than in adults. And so when you have somebody who has a major mechanism of injury, you always have to be thinking about, is there more than one injury? Okay, so if you have an abdominal injury, it's likely that you might have a long bone fracture, you might have a head injury that goes along with it. Their anatomy is different, and their abdomen is structured a little bit different. So the liver and the spleen are less protected by the rib cage. So in an adult, the liver is actually up underneath the rib cage, and the spleen is pretty well hidden, but they're more exposed in a child. Also, the bladder doesn't sit down in the pelvis as much as an adult, and so the bladder is more vulnerable because of this shallow pelvis. And the head is proportionally larger in a child than it is in an adult. And so if you think about the anatomy and how it fits together, it really looks like Charlie Brown here. Okay, he's got a big head, he's got kind of a short, stubby abdomen, and this different anatomy really, changes the kind of the anatomical nature of the injuries. One of the key things about kids is they have a lot larger body surface area compared to their body mass. And the main physiological consequence is this, that they lose heat very rapidly. Okay, so a lot of area, small mass, lose heat quickly. And as a consequence of this, you can get hypothermia fairly quickly. And it doesn't take long for a child in a cold room or with cold IV fluids or with inhaled gas that's not warm to get really cold. The other thing is kids are poorly insulated compared to adults, and if you compare like the amount of fat on a baby compared to an adult, the kids are just less likely to be as well insulated. A good rule is that usually your temperature regulation system matures by about 10 years of age, and after that, kids pretty much can regulate their body temperature similar to adults. But in kids under 10 years of age, you really have to be concerned that they're at high risk for getting hypothermia. So what we tend to do is try to make sure the kids are in a warm room, that there are blankets, that we use warm IV fluid, and that when they're being ventilated that the gas is warm. Kids are psychologically different than adults as well, and all of you who've taken care of kids in the hospital know this. If you've babysat your friends, kids, this. If you have children yourself, you know this. Kids, when they get into unfamiliar surroundings or experience stressful events, it's very common for kids to become uncooperative. One of the things that happen in very young children is that they have this emotional instability, which can lead to regressive behavior. In other words, if you have a stressed out 10-year-old, all of a sudden they're acting like a 6-year-old, or if you have a stressed out 6-year-old, they're suddenly acting like they're 2 or 3 years old. So if you kind of anticipate these behavioral and these emotional problems, then you're better able to kind of deal with the situation. And then I think there's increasing recognition that multi-system trauma patients, that multi-system trauma can profoundly affect personality. And that goes along with learning problems, how the child, after major injuries, adjusts to the families and adjusts to their social situations. And that's probably true for adults as well. One of the really basic things that I think helps taking care of kids is knowing what the normal vital signs are. And vital signs change by age. So in general, your heart rate gets slower. Your normal heart rate gets slower as you get older. Your blood pressure increases and your respiratory rate increases. And so you can see that what you really need to know is what the normal vital signs are. So a pulse of 160 in an infant under 1 year of age means something completely different than a heart rate of 160 in an adolescent. And so what's valuable is to have this sort of information just posted on the wall if you're going to be taking care of kids and you're not familiar with a lot of these numbers, or just to have some basic numbers in your head. And one of the things I always try to remember is systolic blood pressure, and a really easy way to get an idea of what your normal systolic blood pressure is, it should be about 70 plus 2 times your age. So for example, the normal systolic blood pressure for a 5-year-old would be 2 times 5, which is 10 plus 70, so it's about 80. So I think knowing where these numbers are, or what the normals are, really helps you when you're taking care of any patient at all or any child. One of the key things about kids is they also respond to shock differently, and they have different compensatory mechanisms than adults. One of the key things when you're thinking about trauma patients is children have a limited ability to increase their stroke volume. And so what kids do when their heart rate goes up, they do it by increasing their heart rate. They also have a labile peripheral circulation, which can make them very difficult to assess. That's by just like trying to examine them clinically. You're looking for capillary refill and peripheral pulses. They tend to have this labile peripheral circulation, which changes with injuries and also the amount of stress they're having. The other thing is children have an increased ability to redirect blood flow to priority areas. And one of the consequences is if you have a peripheral injury, a lot of times this blood circulation is away from the central area. And one of the consequences is that kids tend to have more of an ileus, okay? And one of the things that's very common in kids is when they get injured, they get an ileus. And along with the fact that they tend to swallow a lot of air, their bellies get really distended. So one of our practices in any severely injured child is to always pass a nasogastric tube. And a lot of times by just placing the nasogastric tube, you can increase your ability to examine the child. So usually a child will come in with a severe trauma, will be stressed out, have swallowed a lot of air, come in with a big abdomen, and by passing a nasogastric tube, you can basically get a better exam on the individual. So this is not data from a real patient, but it's kind of a what I would consider a prototypic 10-year-old response to shock. And so if you see there's 2 axes here. There's blood loss. Okay, so that's percent blood loss on the horizontal axis, and then on the vertical axis is systolic blood pressure and heart rate. Okay, so what kids tend to do is they let's just look at systolic blood pressure. So if you follow which is shown in a red line, I don't know, for systolic blood pressure, the kids can maintain their blood pressure pretty well. Okay, in an adult, what would happen is when you get out to 15, 30, and 40%, the blood pressure starts drifting down. But what happens in a child, they respond to this hypovolemia by increasing their heart rate. Okay, so their blood pressure is relatively maintained for a long period of time, but what happens is then they get severely tachycardic and all of a sudden they crash. Okay, so what you need to remember from this is that severe tachycardia potentially means impending cardiac collapse. Okay, and which is a little bit different than an adult, because what you see in an adult, the blood pressure starts written down, you get not so much tachycardia. The other thing is in a child, if you have bradycardia is hypoxia until proven otherwise. Okay, and that's something to remember. It's always in a child. Bradycardia, hypoxia means you have an airway problem and you need to improve the oxygenation. And by far, the most common cause of arrests in children or respiratory arrests, okay, not a failure to manage the airway. So let's kind of shift gears and talk a little bit about abdominal trauma. And so what I wanted to do is kind of set the frame by talking about some of these general principles. So I've divided this part of the talk into a couple different sections. What I'm going to do is give you kind of a brief overview of abdominal trauma in children, talk a little bit about diagnosis, and then it's impossible to talk about every aspect of management, but what I've done is pick the things that I think are the most common. So we'll talk a little bit about management of spleen injuries, liver injuries, pancreatic injuries, duodenal injuries, and a little bit about hollow viscous injuries. And these probably fit into about probably 95 or 98% of all the injuries that we see in kids. Now I'm not going to mention penetrating injuries, but the principles for managing penetrating injuries in kids are basically identical as in adults. If you look at just how common abdominal injuries are, abdominal injuries account for about 5% of children admitted to the hospitals for injuries. The mechanisms vary, but they're probably the most common are motor vehicle accidents, blows to the abdomen, child abuse, and then penetrating trauma, which varies depending upon what part of the world you live in. Overall, the mortality from abdominal injuries is about 10%. But remember that a lot of these kids who have severe abdominal injuries also have severe head injuries and other injuries as well. But blunt trauma in most places in the United States accounts for about 97% of the injuries. With regards to physical exam, it can be kind of difficult to determine if a child has an abdominal injury. Usually what happens, you have a 5-year-old who comes in who fell at school off the monkey bars or something. The kid's screaming. The parents are anxious, and it's really difficult to examine the child. And sometimes it's very almost impossible to determine if the child has a significant injury. And as I mentioned before, stressed children tend to swallow large amounts of air. Okay, so what we would like to do is pass a nasogastric tube. I have a pretty low threshold for just doing that right away. Of course, if you have facial fractures, you want to pass an oral gastric tube rather than a nasogastric tube. And then it's also not too uncommon to have a big distended bladder. And so by decompressing the stomach and decompressing the bladder, a lot of times you can get a pretty good exam on the patient and make an assessment about the likelihood of an injury. The other thing to remember in kids is that pain management is really important. I'm sure that applies to adult patients as well. I'm a big believer that serious clinical signs are not obscured by pain medication. And with children, what you want to do is give the narcotics IV in small and frequent doses. And the thing to do is to get used to using one narcotic. My preference is morphine. And that way I use it. I'm pretty familiar with it all the time, and I know exactly the doses. I know how kids should respond. Other people tend to use fentanyl, but I think it's good to get used to using one medication. By far the most accepted way of diagnosing abdominal problems in kids are contrast enhanced CT. Okay, we don't use very much ultrasound at all in the trauma patients at Children's. There's probably an opportunity to do it in selected patients, but CT is probably the diagnosis of choice to really exclude a significant abdominal pain in a child. It's really a reliable method for detecting, localizing, and quantifying intra-abdominal injuries. The key thing, though, is it does not predict the need for repair, okay? Because everybody who has blood in their abdomen, that doesn't mean that you need an operation. This is one of the reasons why DPL went along the roadside in children's, because if you had a positive DPL, you really didn't know what to do with it, because there was a tendency to manage more and more of these kids non-operatively. Now in the literature, they always say about 5% of abnormalities need exploration. I think it's probably less than that, and it might be that the patients that we see. So there's some key things here. The first is that the hemoperitoneum does not indicate need for laparotomy. Okay, as I mentioned, most of these injuries are managed non-operatively now, and even pneumonia alone can be misleading. So it's possible to have a trauma patient, as you know, who has a CT with a little bit of air, and a benign exam. And it's always difficult to sort those patients out, but you always have to think about other causes of pneumoperitoneum, and especially in children, you worry, you think about, thoracic injury and dissection of air down in the abdomen. But, anytime you see pneumoperitoneum on a CT scan in a trauma patient, you worry about a hollow viscous injury. But you need to, consider the whole clinical picture. So here are the kind of the accepted, or what I think are the criteria for an abdominal CT in a child, and these probably are very similar to what you do in an adult. First of all, hemodynamic stability, which means you have to be able to safely get the patient to the CT scanner without them arresting, okay? Anybody who's really hemodynamically stable needs to be in the operating room. There needs to be a potentially significant intra-abdominal injury by history or examination. In other words, what you want to do is selectively use CT, not CT everybody. So if you have somebody that you suspect has a very minimal mechanism of injury with a benign exam, then that's probably not a patient that needs to CT. Another criteria is significant initial fluid resuscitation without an obvious source of blood loss. So if you have a patient that's hemodynamically unstable and you're given large amounts of fluid resuscitation and you aren't making any progress, then you need to be worried about intra-abdominal bleeding. And then multiple system injury, especially associated with head trauma. And this goes back to the theme that if you have one injury, there's a likely that there's a chance of another injury. And you can see this CT on the right there. There's a large pneumoperitoneum and a lot of fluid or a lot of blood.
In my teaching the pediatric CT scan, it's important to have oral contrast. Is that the case?
Yeah, we usually do them without. Okay. Yeah. It depends what you're doing, but it's IV contrast, and they're done quickly. Even our studies will, like appendicitis, we don't use oral contrast. I mean, there are times that you want to give it, but the vast majority we don't do it. And there's a couple of reasons. One is that most of these kids will have an ileus. Then the other thing you have to do is give the contrast and wait for it to go through. So most of them get, just IV contrast. So, but there are some instances where it will help. And when I talk about duodenal injuries, I'll show you a picture of a CT you're probably thinking the same thing, which you're probably thinking about a duodenal hematoma.
It's more because of the lack of fat brains in children versus in adults.
Yeah. So we don't routinely do that. So so let's talk a little bit about management and non-operative management of solid organ injuries is currently favored in hemodynamically stable children. But the question is always, when do you operate? Okay, because even if you can manage the vast majority of kids non-operatively, there's always kids that you're going to need exploration because they're either bleeding too much or they have a life-threatening injury. And so the general indications for laparotomy are acute deterioration. In other words, you think you got bleeding someplace that you can't control. Peritoneal penetration. In other words, you got it's a stab wound to the abdomen or a gunshot wound. Evidence of a GI perforation. In other words, you got a lot of free air when you did the CT. Persistent hemorrhage. And a general rule is that you have a transfusion requirement that's about half the estimated blood volume, which is about 40 milliliters per kilogram. So remember, when you fluid resuscitate a child, what you usually do is give fluid boluses of 20 per kilo, okay? And that actually comes from the concept that your blood volume is about 80 cc's per kilo. So when you're given a fluid bolus of crystalloid in a child, you're given about a quarter of the blood volume, okay? So that's where those kind of numbers kind of come, okay? Again, these are not, a lot of these numbers are not hard and fast, but a lot of it's clinical judgment. So let me kind of go through in a little more detail of how we arrived at the management of like these splenic injuries. And there's really three things that have really led to this non-operative management of splenic injuries. And the first is the recognition that bleeding usually stops in splenic injuries. And I haven't taken a spleen out in a child in probably 5 or 6 years, okay, because it almost never happens, okay. There's also this recognition that the spleen is, damn important when it comes to immunological importance. And then with the advent of CT, it's really allowed us to localize injuries a lot better. So, and make sure that there's not other injuries. So it's really those three things that have kind of contributed to the development of non-operative management of splenic injuries. But again, the management depends on the physiological status of the patient. So even if you have if you have a problem that doesn't look bad on CT, it's still a possibility that the patient will need an operation. Okay, so again, the indications for operation are ongoing blood loss, suspected other injuries. So for example, it's possible to have a splenic injury but also have a bowel perforation, and then you would want to operate on that that bowel injury. And then when you do operate on these patients, what you want to try to do is salvage the spleen if possible. And that includes, there's a number of different techniques that you can do. You can directly suture the spleen, which doesn't work all that great. You can do a partial splenectomy. You can wrap the spleen in an absorbable mesh, something like Vicryl. On the right side here, you see a CT of a splenic injury, and on the lower right, you see somebody doing a splenectomy. And I pulled that off the internet. It doesn't look like a banged up spleen. It almost looks like a normal spleen. So I'm not exactly sure what they were doing that splenectomy for, but it doesn't look like a spleen that needed to come out for trauma. The origins of all this non-operative management of pediatric solid organ injuries goes back to the 1950s, and it kind of evolved over the next what is now probably 60 years, and it probably even led to a lot of the thinking of non-operative management in adult injuries. Okay, and really the original description was from a paper by Schumacher in I think it was 1956. Okay, and what they recognized was that, and these were a series of kids who had splenectomies for hemolytic anemia, and all these kids died of sepsis. Okay, and since there's been a lot of research on this concept of overwhelming post-splenectomy sepsis. Okay, and just some of the numbers that I kind of keep in my head is, for example, a child who's had a splenectomy, mortality due to sepsis is about 58 times of what it is in a normal population. Okay, and this overwhelming post-splenectomy sepsis is really, a real danger with a high fatality rate. So the lifetime risk is about 5%, so it comes out to about 3.3 to 4% per year. But the mortality has been described between 50 to 70%. Now I don't know if it's that high anymore with the advent of more modern antibiotics, but the old series really described a mortality rate that was exceedingly high. And most of these overwhelming post-splenectomy sepsis patients are infected with encapsulated organisms, especially Streptococcus. Okay, so whenever you have a splenectomy patient, what you need to do is be thinking about, how do you keep that child from getting post-splenectomy sepsis, okay? And there's a number of strategies, and they include immunizations, okay? And there's now a polyvalent vaccination for Streptococcus pneumonia. There's now a Haemophilus influenza vaccination, and also for Neisseria meningitidis. And then prophylactic antibiotics with penicillin. Educating the parents is incredibly important. A lot of people will give the parents antibiotics, kind of standby antibiotics if the child were to get really sick, and then to use a medical alert bracelet. So let's shift to liver injuries. Okay, and liver injuries can be serious, and they can cause a fair amount of morbidity and mortality. Up to about 40% of pediatric patients with liver injuries die before arriving to the hospital. These patients probably have injuries to their hepatic veins or inferior vena cava. And so patients with any kind of hepatic vein injury or an IVC injuries has really high mortality. Again, non-operative management is recommended if the patient is stable. But there are indications for operating, and in my mind they include profound hemodynamic instability, evidence of continued bleeding, and associated injuries that require exploration. But what tends to happen in these patients, and I'm sure that happens in adults, is you have a major injury, and especially in a child, if you have massive bleeding, you get a coagulopathy and the child gets cold. And some of these patients will need to be packed and then brought back to the operating room. But again, it's a small percentage of the patients that can be managed non-operatively. So here's what we do at Children's, okay? And we have what's called a liver and spleen injury pathway, which I think is really kind of helpful in organizing the care of these patients so it's more consistent. And these are some guidelines that were outlined by American Pediatric Surgical Association. And so we just basically divide the injuries into mild injuries, moderate injuries, and severe injuries. And according to that determines where they go. So if they have a mild injury, which used to be the old grading of 1 and 2, they would go to a medical surge ward, which is monitored. For a moderate injury, which is an old grading of 3, they would go to the intermediate care unit. And then severe injury, which is the grading of 4 or 5, they would go to the pediatric intensive care unit. And then this is all on the computer, so if we have a patient with a liver or spleen injury, we can just compare the CT scan to what the findings were and where the patient should go. So for example, let's just look at mild injury. So the CT findings in a mild injury would be a small subcapsular hematoma, less than 50% of the surface area, simple linear fracture less than 3 millimeters in diameter, intraparenchymal hematoma less than 2 centimeters in size, and none to small amount of free fluid. So what this does is it kind of allows us to figure out in a really simple way where we should send these patients. So it kind of standardizes things. So, and then the other thing we have is we have standard discharge criteria, okay? And again, these are APSA discharge guidelines, okay? And these are based on injury severity and also when the clinical criteria are met. So for example, in order to go home, you need to have stable vital signs, you need to be tolerating a regular diet, you need to have your pain controlled with oral pain medication, you need to have a stable hematocrit following ambulation. And then the general guidelines for a mild injury would be 2 to 3 days, moderate 4 days, and severe 5 days. But again, these are just guidelines. And I think the last major hepatic injury that a patient I had, I kept at bed rest for 7 days, thinking that his injury was such that it looked like there was a fracture right down to where his inferior vena cava was, kind of retrohepatic vena cava. Now, I think again that one of the key things is here is, how well does all this work? And the challenge is always to sort out, these patients that need to be operated on. So what I did is I looked through the literature a little bit, and there's a couple recent papers on liver injuries and high-grade splenic injuries in children. So these are 2 papers. The first is an article called Liver Injuries in Children, the Role of Non-Operative Management. And this paper comes from the Red Cross Children's Hospital in South Africa. And they had 311 patients over a 22-year period. 4% had a liver-related laparotomy, and they had about 1% in that group. But again, the vast majority were treated successfully without an operation. So I think that pretty well demonstrates that most of these injuries can be managed by non-operative management, but they're clearly patients that you need to operate on. Okay, and then the second paper was management of high-grade splenic injuries in children. This is American in surgery in 2008. And I think again the challenge is not to know what to do with most spleen injuries, because most of them are small and they're just going to get better by just sitting the kid in bed for a couple of days and sending them home. But again, this points out that there are kids who will need a laparotomy. Okay, so this is data from the National Trauma Database. They had 413 kids with high-grade blunt splenic injuries. The abbreviated injury score was 4, was greater than or equal to 4. Their operative intervention in that was 42%, and their overall mortality was 13%, which I think that seems kind of high. There was a recent paper that came out of Boston where they were, and correct me if I'm wrong, but I think the National Trauma Database includes all comers. It includes pediatric hospitals, general hospitals, and there was a recent paper from Boston looking at the rates of splenectomy in different populations at different hospitals, and it was tended to be higher in adult hospitals and pediatric hospitals. So, but again, I think it points out a couple things that non-operative management works. Okay, it doesn't always work, and then the thing you got to do is try to select, your patients, and there is still mortality associated with non-operative treatment. So now we could talk about pancreatic injuries, for a whole day. But here are just some key concepts about pancreatic injuries in kids. The first is that trauma accounts for about 50% of cases of pancreatitis in children. So whenever I am consulted on a patient with pancreatitis, the first thing I always ask is was there any injury? And the injury mechanisms are usually motor vehicle accidents, bicycle handlebar injuries, getting hit in the stomach. And this is actually a CT from somebody who had a bicycle injury. And you can see where the arrow is that they essentially cracked the pancreas completely in half. Serum amylase and lipase are very helpful in making the diagnosis. Most pancreatic injuries can be managed non-operatively. A lot of times, a little bit of pancreatitis just goes away. The more complicated injuries will tend to form pseudocysts. Pancreatic duct disruption, as noted in this CT, is pretty rare. The treatment for a distal duct injury is a distal pancreatectomy with splenic salvage. But I didn't take care of this particular patient, but it looks like the appendix or the pancreas is transected right, 2/3 the way down from the distal end. So what I would probably do if I saw that would just leave it alone and wait for it to form a pseudocyst and hope that it would heal. So duodenal hematomas, and I think you kind of alluded to that before. If you have the oral contrast can help make the diagnosis. Basically, a duodenal hematoma is basically you get massive kind of intramural bleeding in the second or third segments of the duodenum. And the reason that you get an injury there is that's the part of the duodenum that's a little more fixed. And you can get these massive duodenal hematomas. And the thing to remember about them in kids is that most of them just go away with nasogastric suction and some TPN. But it can take anywhere from 2 to 3 weeks for a big duodenal hematoma to resolve. The common clinical presentations are gastric dilatation, bilious vomiting, and epigastric mass, which is essentially what you see from a duodenal obstruction. It usually is confirmed with a CT or an upper GI. Okay, and as I mentioned, they usually resolve without any surgery. Hollow viscous injuries in kids usually involve the bowel or bladder. They're sometimes very difficult to diagnose, so you really have to have a high suspicion that there might be a hollow viscous injury. When you first see trauma patients, they may have a hollow viscous injury and have a completely benign exam, and the peritoneal signs may take hours or even a couple days to evolve. And so here's the classic patient, okay, who was a girl who was involved in a high-speed motor vehicle accident. She has a belt on, and she comes into the hospital and she's got a hematoma across her abdomen, but she's got a benign abdominal exam. Okay, so whenever I see any ecchymosis across the abdomen, what I'm thinking is this patient has a high risk for having a bowel perforation. And the first thing I'm going to do is, even though this child has a benign abdomen, I'm going to admit the patient, because even if the CT doesn't show any free air, there's a chance that there's a small perforation that was missed. Now, in this patient, there was an X-ray that shows some free air. And then the other thing is that with this lap belt complex, it's really it's a number of different things. It's abdominal or flank contusion, okay, and this girl has a kind of an abdominal wall contusion, the intestinal perforation, and also lumbar spine injury, which can be anything from a vertebral fracture to a severe cord injury with paralysis. The last patient that I operated on with a hollow viscous injury was exactly similar to this patient, but it was a child who was involved in a motor vehicle accident, a boy about 10 years old, and I was amazed at the amount of injury he had in his abdomen. He tore his bowel in 3 or 4 places. His mesentery was completely shredded, and he had just a teeny tiny amount of free air on his CT. So they can be pretty significant. But I think one of the injuries that always gets missed in kids is that this classic patient. They come in, they got a benign abdomen, their vital signs are completely fine, their labs are okay. They have a little bit of ecchymosis, they get sent home, and they're coming back a couple of days later with a bowel perforation. So just to kind of, to give some conclusions, most pediatric abdominal injuries occur as a result of blunt trauma. Spleen and liver are the most commonly injured organs from blunt abdominal trauma. Bleeding from an injured spleen or liver usually stops spontaneously, although there are patients who require exploration. And non-operative management requires the ability to observe these patients closely. And I can't emphasize that more than anything else, is if you're going to do non-operative observation, you have to be able to monitor the patient closely and intervene quickly should the clinical status of the patient change.
Steve, thanks a lot for the review. Quick question on the pancreatic. I read a paper actually from Graves showing a pretty high success rate of ERCP and stenting.
Yeah.
What's your experience in that?
That paper was actually published by Tim Canty, who is one of the pediatric surgeons, and I try not to do that. What I like to do is just leave them alone. Okay, and the last patient I had like that had a severe, looked like a pancreatic transection in the proximal third of the and everybody said, you need to do ERCP and stent this and everything. And we kind of did as a group, decided that we'd just leave the kid alone and let a pseudocyst form. And a small pseudocyst formed, and the kid completely resolved. So I think part of the problem is it's hard to determine how severe an injury is based on CT. Now, the other thing I worry about is ERCP, is you're blowing bacteria back up into your pancreatic duct, and you're shooting contrast. And I worry about contaminating, the pseudocyst or the injury with bacteria. So, one of the gurus in pancreatic, injuries and managing pancreatic problems is Dr. Musa. Okay, and I remember having some discussions about these sort of injuries with him, and he always says, just leave them alone. And then the last thing I was going to do is just, mention the importance of injury prevention, because, most childhood injuries are preventable, and the numbers are actually, pretty amazing, because the first thing is that with childhood deaths, about 60 to 70% of childhood deaths occur before they get to the hospital. Okay, so really, if you're going to have any impact on child deaths from in trauma, you got to do prevention. Okay, and then the other thing is to remember is that you can reduce injury rates by about 50 to 75% with well-designed programs. So, so it's always important to be thinking about, injury prevention and how it fits all together. So.